Good morning, everyone. So this is the second lecture in the series on the topic of biopsy. So last week we had discussed uh, what is biopsy, types of biopsy, and in details about incisional biopsy, scalpel biopsy, punch biopsy, brush biopsy, and this week we will discuss FNAC, frozen section, and what tissue needs to be submitted to biopsy. Alright, so when we look at the terminology FNAC, okay, it stands for fine needle aspiration cytology or fine needle aspiration biopsy. So I'll tell you what exactly is the difference between the two. Alright, now this biopsy procedure is done for swellings. Alright, please remember this is done only for swellings. Okay, so these swellings could be on the head and neck, could be intraoral, mostly is done for extraoral swelling. So here you can see that there is a swelling here on the neck. Alright, a very localized swelling, a well-defined swelling here. And in these cases, when you want to actually identify or come up with a diagnosis, what you can do here is a procedure called fine needle aspiration cytology or FNAC. Okay, now the basic difference between FNAC and FNAB is basically if you use a fine gauge needle, a finer, thinner gauge needle, then you call it an FNAC. But if you use a wider bore needle to collect tissue instead of cells alone, then you call it fine needle aspiration biopsy. Okay, so that's the basic difference. We'll look. Okay, so now this is the FNAC Armamentarium. So as I just mentioned, these are the various types of needles that can be used for a fine needle aspiration. Right on top here is a tissue core biopsy needle. Okay, and these needles here are finer needles. So as I mentioned on the previous slide, when you use finer needles, you call it an FNAC. If you use a broad gauge needle like the needle here on top, then it becomes a biopsy. That's because when you use a finer needle, you're actually collecting cells, individual cells. But when you use a wide bore needle like the needle here, it actually collects tissue. All right, or that's why it's called a fine needle aspiration biopsy. So for a fine needle aspiration biopsy, we use a tissue core biopsy needle, whereas for a fine needle aspiration cytology, you use finer needles. All right. In addition to this, what else do we need? Right. So we have a kit like this, right, wherein you have the syringe, the needle, you have the holder here, okay, which comes as a kit. Okay, you have the microscope obviously to examine the slide, you have a fixer, you have glass slides, and these are the processing liquids for basically staining the slide. Okay, so this is also called a mobile FNAC card because once you do the procedure, you actually immediately prepare the slide and then you fix it, stain it, and you can observe it. Right. So moving on, I'm first going to run you through the steps of the procedure, and then I'm going to show you the pictures of how it's actually done. Okay. So first step is that, as I told you, we do it for swellings. So if we have an extraoral swelling, then you localize and stabilize the mass, okay, with your fingers, and with the other hand you insert. The next step is the insertion of the needle into the swelling. Okay. The step after that is aspiration of the contents of the mass in different directions. I'm going to show you how that's done. Okay, and next step is withdrawal of the needle. That means after you've aspirated, you withdraw the needle, and last step is you transfer the material from the needle onto a glass slide to prepare the smear. Okay, so these are the basic steps. So localization, stabilization, insertion of the needle, aspiration of the contents, withdrawal of the needle, and then transfer of material from the needle onto a smear. Now, as I show you on the next slide, how important is this step here? All right, that means after aspiration, when you're withdrawing the needle from the lesion and transferring the material is among the most important steps, or rather, this is what makes it a very technique sensitive biopsy technique. Okay, so I will explain to you in the following slides. Right, so for easy understanding, these are pictures from a textbook. All right, and here the image that is shown is that of a fruit, an orange, very commonly available fruit. And when you say localization and stabilization, this is what it means. Basically, you hold your finger, you use your hand to stabilize the lesion so that it doesn't move during the procedure. Okay, the second step, as we had just discussed, is insertion of the needle. So now please pay attention carefully to this. At this point, when you are inserting, okay, the plunger is at uh, at the base, okay, is at the base, and the needle is penetrating into the lesion. So here we are imagining that this orange is similar to a swelling. The step after that is there is negative pressure that is applied. Okay, you see the plunger has moved back, negative pressure that's applied, and while you apply negative pressure, the needle is moved around inside the lesion in a circular manner. Okay, this is done in order to be able to take representative cells from the lesion. Okay, and this, when you do this, the negative pressure is applied, and the next step is the plunger moves back to uh, to the base, and only then you withdraw the needle. Okay, now this is a very important step. Now these two steps are very important. The reason being that when you apply this negative pressure, we have to take care that the contents that we are trying to withdraw from the lesion do not come into the syringe. The reason being that if they come into the syringe, then it's no longer an FNAC, because the contents, to put it back onto the slide, are very difficult, and we lose contents or cellular contents that we are trying to biopsy over here. So the aim here is to collect the material in the hub of the needle. Okay, in the needle. That is our aim as part of this biopsy. Okay, so once you apply negative pressure, you swiftly move it inside move the syringe inside the lesion, and then you bring the plunger back, and then you take out the needle from the lesion. Step after that is you disengage the needle. All right, you fill air into the syringe. All right, and then force the content out onto a glass slide. Okay, why do I say that this is an important step? Is because if you forget to disengage, that means if you forget to take out the needle while you are actually filling air in the syringe, then the contents again from the needle will get aspirated into the syringe, and you will not be able to transfer the material onto the glass slide. So that is how important and technique sensitive this biopsy procedure is. Okay, so this is how an FNAC is done, fine needle aspiration cytology. Okay, once the content is transferred onto the slide, you use another slide to apply pressure and move it move it to create the smear. Okay, so this is basically a one-step smear. The top far edge of the spreader slide is lowered onto the specimen droplet, and gentle pressure is used to flatten the material. And once it's flattened, it dries, and then it's stained, and it is examined under the microscope. So this is how an FNAC is done. So in summary, okay, I'm going to run through this again because as I mentioned, it's a very important and technique sensitive biopsy. All right, so number one is localization and stabilization. Okay, pierce the lesion using a 25 to 21 gauge needle, a 2.5 ml syringe. Okay, so you go in, right, you withdraw the plugger, creating a vacuum. All right, 2 to 4 ml, and without exiting the lesion, redirect and fan the lesion. That is, direct the needle along a number of different tangents. Right, that means you move it around inside the lesion while you are applying negative pressure, ensuring that the content does not come into the syringe. Right. Next step is release the plugger, returning the vacuum to base or 0 ml. Exit the lesion. The step after that, detach the needle from the syringe, right? Fill the syringe with air. This is the most important step, as I told you. If we go wrong over here, that means we forget to take out the needle and fill air into it. All the content that we have collected, the cellular content, it will get stuck inside the syringe, and we will not be able to prepare the smear. All right. So we fill air into the syringe, connect the needle back, and then push the air out. When you push the air out, the contents come onto the slide, and thereafter you prepare the smear, and that's how an FNAC is done. All right. So very important learning messages here. Number one is a biopsy technique that's done only for swellings, usually done for extraordinary swellings. Okay, and uh, it's a very technique sensitive biopsy procedure. Okay, right. So this is fine needle aspiration cytology. The difference between fine needle aspiration cytology and fine needle aspiration biopsy is the wider gauge of needle that is used for FNAB. Okay, right. So let's move on to the next biopsy technique, which you should know. All right, and this technique is called frozen section biopsy. Okay, now frozen section is a rapid tissue sectioning by cooling the tissue with the help of a cryostat to provide immediate report of a tissue sample. All right, the cryostat is an instrument to freeze the tissue and also to cut frozen tissue for microscopic sectioning. All right. Now this is an infographic over here. So if you see this gentleman over here, he is a pathologist. Okay, the procedure he is doing here is called a frozen section. Okay, so now this box shaped instrument that you actually see here is a diagrammatic representation of a cryostat. And a cryostat is a machine that can actually freeze tissue right up to minus 25 degrees centigrade. So the temperature that is maintained inside a cryostat is minus 25 degrees centigrade. Basically, a cryostat is like a super cool refrigerator which has a microtome inside it. I'm sure you guys all know that microtome is a device, an instrument that is actually used to section tissue to produce uh, histological slides and for basically biopsy examination. Okay, now frozen section. Okay, why do we need to actually do a frozen section, or where is this actually applied? Okay, a frozen section basically is instant freezing of tissue to be able to make it firm, to be able to section it to a certain extent, then to create a slide, stain it and diagnose it. That's the aim. Okay, so now frozen sections are basically indicated for intraoperative diagnosis. That means, you know, at a regular play during a regular where do we use this? You know, this setup is usually quite is placed right next to the operation theater where our colleagues, surgeon colleagues, are doing a particular surgical procedure, and they need to know the diagnosis while they are doing uh, the procedure, so that it can direct their surgical treatment. That is where we do it. So that's why we call it intraoperative diagnosis. All right, so basically what happens is there is something called as a cryo embedding fluid that is used to basically freeze tissue. Okay, to freeze tissue, right? So as you all know, human tissue, okay, any part of the body is basically 96% water, and we cannot use water to freeze the tissue because we cannot section it once we freeze that. So there are commercially available specialized freezing medias, okay, which are used to freeze this piece of tissue instantly inside a cryostat. Okay, so here as you're seeing, the biopsy that has been removed by the surgeon is placed in the middle of the chuck. Okay, it is filled up with the cryo liquid, and then a chuck is placed over it. This entire procedure is happening at minus 25 degrees centigrade. So within a few seconds, what happens is the tissue freezes. All right, tissue freezes, and we have a block like this. Okay, now the fact that you guys have already learned about tissue processing, you will know that during regular tissue processing, what we do is basically, once the biopsy is done, you have that piece of tissue that goes into formalin, and then the tissue gets fixed, and then there's a whole processing that takes place wherein the water inside the tissues is replaced by by, by xylene, and then replaced by wax, and then we create something like a wax block which we use to actually section tissues. Okay, that's currently the the processing for biopsy that is done. Okay, now here, because we need instant diagnosis, we cannot go through that entire wax processing, and so we do something called as cryo embedding, which freezes the tissue at minus 25 degrees centigrade, making it firm enough to be able to go through sectioning. Okay, to be able to go through sectioning. Now this is how sectioning is done. All right, so this is the microtome. You have the block placed over there and the thin blade placed over here, and when the microtome is rotated, right? You get these thin sections. These sections are then immediately stained, and then intraoperative diagnosis is given to our surgeons. Okay, so indications for frozen section usually are intraoperative diagnosis, as I mentioned. Most commonly is something for like margins of tumor section. Okay, so for many of you who do not know what exactly margins of tumor section are, I would like to explain here. Let's imagine this to be the buccal mucosa. Okay, let's imagine this to be buccal mucosa here. Okay, I'm just trying to do this. Let's say there is a tumor over here. All right, let's say squamous cell carcinoma, which is being removed. Okay, so what generally happens is the surgeons leave a normal margin around the tumor. Okay, and then they take out this whole thing so that uh, the area is disease free. What happens is that you actually want to identify, despite the fact that physically we are able to see the tumor here, microscopically we could have tumor cells anywhere in this, even though it's looking normal, right? So what happens is when the surgeons remove this piece of tissue, they actually send each of this tumor margin, okay, anterior, superior, posterior, okay, inferior, okay, they send each of this to the pathologist in the next room to do a frozen section to be able to tell us that whether this margin is free of tumor or no. Okay, so this is a great example of where frozen section is used. I hope you get that. If let's say the report says that no, these three margins are free but the anterior margin is not free, then what happens is they further resect more tissue so that eventually the treatment that they have done, surgical treatment that they are doing, ends up free of tumor margin. However, if we reach a point beyond which it cannot be resected because either there is a very important organ, an artery, or any other structure passing through that, what happens is that you leave behind tumor cells over there, and then that's the reason why post-operative radiotherapy is given specific to that site. Okay, this is a very broad general information that I'm trying to give you so that you understand the concept of frozen section over here. Okay, I hope this makes this clear. Okay, so this is where we right. So now coming to the most important learning outcome. All right, the most important learning outcome as to what do you submit. Right now, as undergraduate students, as I mentioned, it's very important for you to be able to first of all identify where biopsies are done, what types of biopsies are there to be able to describe them, then to be able to fill out a biopsy form. Okay, because as an undergraduate student at PIDC or at any dental school, you will follow your lecturers as well as your seniors in when these procedures are done, and the first skill that you learn is to fill out content on a lab form that goes to the lab. Okay, and that is an important procedure. It's an important step that you learn. Okay, so what do you submit? So all tissues removed from the oral maxillofacial region except, okay, except teeth without soft tissue. That means regular extractions that are done in which there is no periapical tissue that is found attached to the root surface, we do not need to submit that. Second, extirpated pulp tissue. Now extirpated pulp tissue is tissue that is removed when RCTs are done. Okay, now the reason this tissue, although it's human tissue that is being removed, we do not submit for biopsies is because evidence as until now does not show any metastatic diseases that come to the pulp or any major diseases, life-threatening diseases that can occur inside pulp tissue. All right. The third type of tissue that we do not submit for biopsy is clinically normal tissue. Okay, so if you are doing a procedure and you cut out normal tissue for some reason, you do not submit that for biopsy. Okay, and the last is excess donor tissue from grafting procedures. Okay, so if you are doing a grafting procedure, let's say a periodontal grafting procedure, you take a donor tissue from the palate and then you suture it, but there is additional graft material tissue that is left, we do not submit it. Okay, all other tissues that are removed biopsy, you will have something like a maxillofacial region should be submitted. Now, when this requisition form biopsy has to be filled out by the operator or the assistant. Many times when you're assisting, you would be helping out the operator to fill it up. Okay, at the dental school, the operator is usually the lecturer, and you are observing and assisting on most of these procedures. Okay, but you should help out in filling out this. Now, filling this out is very important. Why do I say it's very important? Is because if you mix this up, okay, let's say there are two procedures of biopsies that are done, and then you mix patient information, it has a huge impact. It has a huge impact on the treatment. It has a huge impact on what is going to be conveyed to the patient. Okay, imagine if you do that between a benign lesion and a malignant lesion, it could be disastrous. All right, so as a student, it's important to copy down this information very clearly and write it down in the designated patients. Okay, so patient information is what generally goes into the requisition form. Who is the submitting doctor? What is the patient identification number? Most important, what is the site of biopsy? You would have to write it down. This is an example of one of the forms that I got from the internet. Okay, we do have a similar form for biopsies that are done at PIDC as well. You can look it up and inside the patient file. Okay, and you mark the site. Let's say you're doing it from the buccal mucosa, and then mark that site. You have to give a clinical description of what was the lesion, what are the complaints that the patient came up with, and a very important part is the clinical differential diagnosis, because you have to understand that this sheet of paper, okay, acts as your eyes for the clinical picture for the pathologist who does not see the patient. Okay, the pathologist only sees the glass slide which comes from processing of this biopsy tissue, but to be able to think what you were thinking when you did the biopsy, it gets conveyed to the pathologist only through this requisition form. All right, so it's very important to fill out the site, fill out the clinical details, fill out the clinical differential diagnosis, and mention what type of biopsy was it. Was it an incisional biopsy? Was it an excisional biopsy? If it was an incisional biopsy, what was the instrument that was used? Whether it was a punch biopsy, whether it was a scalpel biopsy, so on and so forth. Okay, so this is how you are required to fill up the requisition form. Okay, so this brings us to the end of the topic on biopsy. I hope you've understood the core concepts over here, and please go back and feel free to go through the lecture again, and if you have any queries, send me an email, or you can ask your questions on the Google Classroom that has already been initiated. Right, so thank you very much. Have a nice day.